Well, hello, everybody. And again, welcome. We had a little bit of technical difficulties, so I am going to resume our introduction and not repeat my welcome. Our first speaker today is Professor Hanan Balkhy, the first appointed Assistant Director General for the Antimicrobial Resistance Division at the World Health Organization. This flagship program has a mandate to lead the human health response to the emergence of antimicrobial resistance along with relevant stakeholders. Dr. Balkhy is a professor of pediatric ID with over 2 decades of experience in the field of infectious diseases and infection prevention and control. She's also a clinician and a researcher with more than 150 publications. Prior to this appointment, she was the Executive Director of Infection Prevention and Control at the Ministry of National Guard and the Director of the Gulf Cooperation Council Center for Infection Control. She led the WHO Collaborating Center for IPC and AMR in Saudi Arabia for a decade, ending in 2019. She's also the first appointed chair for the Infectious Disease Research Unit at King Abdullah International Medical Research Center at King Saud bin Abdulaziz University for Health Sciences in Riyadh, Saudi Arabia. She's going to give us a global perspective on AMR and the WHO's work to combat AMR. Now, after her presentation, she will answer questions. So if you have questions, please place them in the Q&A and not the chat. Our second speaker is Thomas Joseph. Thomas Joseph leads work on antimicrobial stewardship and awareness in the AMR division of the World Health Organization. He previously worked with WHO's Global TB program as team leader, community engagement, and as a consultant. He has over 30 years experience with non-governmental organizations at the local, national, and international levels in the field of social development and human rights. He's been country director in Ethiopia, Kenya, South Africa, and Lesotho with the international NGOs Action Aid and CARE. He also has extensive experience across India at local and national levels. Today, he's going to talk to us about the WHO antimicrobial policy guidance for integrated antimicrobial stewardship activities. And our final speaker today is Dr. Dhanya Dharmapalan, a consultant in pediatric infectious diseases at Apollo Hospitals in Navi, Mumbai, India. Since 2021, she has served as the national coordinator of the Apollo Antimicrobial Stewardship Program, which encompasses more than 70 hospitals of the Apollo Hospitals Group. She was recently nominated as the Antimicrobial Resistance Task Force member of NatHealth, the Healthcare Federation of India. She is a COVID-19 task force member of the Indian Academy of Pediatrics. Now, you may know that Dr. Dharmapalan was the author of the WhatsApp Tip of the Day, an IAP activity that used WhatsApp media as an educational tool to spread awareness about rational antibiotic use. She's also the co-lead of the PCAS subcommittee on global antimicrobial stewardship, and she is going to talk to us about AMR and antimicrobial stewardship in Indian children. After these last two presentations, we'll have a Q&A session moderated by Dr. Lee Morris from Atrium Health Levine Children's Hospital and Dr. Rana Hamdi from Children's National Medical Center. Both are members of PCAS. With that, I will turn it over to Dr. Balkhy. Dr. Balkhy, thank you for being here.
Thank you very much, Chris, for the great introductions, and thank you for setting the stage for the next hour. I would like to get permission, which I have now, which is good, to my PowerPoint. If you can just confirm to me that you have my PowerPoint and all is good, then I can start. Shall I go ahead?
In presenter mode.
This is in presenter mode. Do you see it now?
Maybe you use the other monitor.
Okay, let's see. This is what I just did.
Yeah.
Is it clear now?
We're still
No?
seeing presenter mode, Hanan.
Okay,
That means we
how
can
about
see the
now?
next slide as well. Now it's fine. Perfect.
Oh, yes, it takes a few seconds for me to reorient on my two monitors. Okay, so again, it's a great pleasure to be with Pediatric Infectious Disease Society. Of course, I've been a member of the society for quite a long time, and I think I would like to thank you for the great work that you do for pediatrics. Again, I'm a pediatric infectious disease person, took care of children my whole life, so being part of this webinar is extremely an honor and a privilege for me to be with you and all of our listeners today. Again, I moved from the bedside dealing with children very quickly at the beginning of my career to looking at the bigger picture of infection prevention and control and leading within the healthcare system that I was in, into the regional perspective and then into the global perspective. But it was only till I came to the WHO that I was truly able to sense the huge challenge that is ahead of us. And even though I was extremely concerned during my 20 years back home, I can tell you that my concern today about where are we heading with antimicrobial resistance and the challenges that healthcare providers might be facing concerns me even more. This is a slide, and again, if Chris, if there's any way that you want to share these slides with the audience, I'm happy to provide them after this webinar. But this is a slide that summarizes several references where one of them showing that a child dies every 3 minutes from a multi-drug resistant sepsis. 10 million AMR-related deaths by 2050, 28 million people living in poverty, by 2050, 1 trillion additional healthcare costs by 2050, a 7.5% decline in livestock. So this is really scary and very difficult to swallow. We always think at the global level that the SDG 3 is going to be hampered if we do not address antimicrobial resistance, but the reality is that AMR is relevant to the food and feed, plants and crops, environment, terrestrial and aquatic animals, and affects not only the 3rd SDG, but another 7 other SDGs not being able to reached by the member states. In 2015, as you probably are aware, that the Global Action Plan on AMR was launched. And immediately after that, the tripartite worked together on developing what is known as TRACS, which is the tripartite self-assessment on their national action plans. We can see in the 2-year step up from 17-18 to 18-19 to 19-20, there's a gradual increase in countries having a national action plan. But the sad thing is that only a small fraction of those countries have a funded national action plan. And this is something that we are focusing on, of course, working under the cover of the heavy pressure of COVID. It's been quite difficult, yet we were still able to get a few more countries sign off on their national action plans. But it's important that we also leverage the COVID response at the country level and try to find the underpinning within universal health coverage, within the health system strengthening, primary health care, the supply chain, and also the innovation aspect of not only vaccine development for multi-drug resistance, but the innovation in access to care and diagnostics that are cheap, affordable, and accurate, treatments that are cheap, affordable, and effective, whether in the human side, animal side, or the environment side. So the division that I'm leading, again, as you've heard, it's quite young. It moved from a secretariat that was mainly trying to address the activities in the different departments to a division incorporating and leading the human health sector and being the major collaborator with the partners, specifically at the organizational level with OIE, FAO, and UNEP, which is the health sectors for the environment, UNEP, the food systems FAO, and the animal health OIE. And what we've tried to do as the two major organizations have developed strategic priorities for the work in the animal and the food sector, that we also will be developing the strategic priorities within the human health sector. And they also underpin and are incorporated within the strategic shifts of the WHO since its transformation, and also the need for leadership within the human health sector. So there needs to be strategically stepping up leadership for AMR. We need to drive the public health impact in every country for human health. We need to identify the research development for better access to quality AMR preventive care, which is all of the diagnostics, therapeutics, vaccines, supply chain, regulatory, etc. And finally, monitoring the AMR burden and global AMR response so we can identify where are we heading. There are also two major areas that we're working on in collaboration with major stakeholders, the World Bank in redefining the cost for addressing the AMR agenda, which was released in 2017 of $9 billion. They are looking into that as this seems to be quite an underestimate. The IHME are also coming out soon with the burden of antimicrobial resistance, and these will put a little bit of an identification of what are we really dealing with when it comes to burden, so that we can eventually have also a return on investment case for AMR, and that will allow us to work with the politicians and the financial partners to really move this agenda. Because as I usually have been saying over this past week, it's not something that we do for the future with AMR. Antimicrobial resistance is an active pandemic. The endemicity of emerging resistance pathogens has been taking place in front of our eye with MRSA, different ESBLs, carbapenem resistance, colistin resistance. And there's also a lack of access in many mid-low income countries to the old and the new antimicrobial agents. With the infection prevention and control being core to maternal and neonatal healthcare, the infection prevention and control at WHO has established core competencies and the core competencies which came out more recently, but the core components of infection prevention and control programs. I'm going to stop here for just a second to spread my IPC strength a little bit. What I'm seeing during this pandemic is that there's this infatuation or mesmerization by the grand IPC implementation with hand hygiene, donning and doffing and wearing gloves and whatnot. And what, you know, I hate to be the pessimist in the room sometimes, but what we're seeing with COVID is what we've been seeing with every small or big outbreak. There's some attention to IPC when all these outbreaks take place by holding on to minimalistic interventions that will mitigate transmission of disease. However, once the outbreaks settle, once the pandemic will disappear, I think it will be business as usual, and the repurposing of individuals into IPC will be lost. And unless we develop a career path and a clear identification of a curriculum for infection prevention control and making them a solid component of the healthcare systems, we will continue having these knee-jerk reactions with IPC with every emerging pathogen. This is an example of the work that we've been doing on the maternal and neonatal care specifically, and the link is here, 6-module training package. Again, there are peculiarities in every subspecialty of medicine and healthcare for IPC. The basic grounds, though, are extremely similar, but there are very unique things that we do in high critical neonatal intensive care units, and there are things that we do different in operating rooms. There are things that we do different in the laundry, the morgue, the food facility, and the operating room, the anesthesia, the sterilization units. There are peculiarities, and all of those programs need to be identified within the healthcare system with people following on the implementation of those activities. I think there are two major days that are part of this Antimicrobial Awareness Week that starts from the 18th till the 24th. So this is our Antimicrobial Awareness Week. On November 20th, there's also World Children's Day, which was celebrated, and we're very happy that it falls within this week so that we can jointly celebrate the work that needs to be done specifically for the pediatric population. GARD-P, or the Global Antibiotic R&D Partnership Platform, is a very active partner with WHO, and in fact they're working and prioritizing new antimicrobials for neonatal sepsis that I would invite you to visit. There's also the International Toilet Day on November 18, which is also extremely important, as there needs to be quick, robust response to open defecation systems, as they are a major vehicle for transmission of pathogens and resistant ones as well. And of course, the pediatric population, women and children, are highly exposed to those risks of acquiring those infections unintentionally and unknowingly. This is just an example of some of the work that we've been doing. In the center here in orange, we've identified as part of enhancing stewardship programs within healthcare systems on when do we and when do we not use antimicrobials in managing COVID as a major now respiratory pathogen that has driven the use of antimicrobials, albeit sporadically, but globally. We are encouraging the abstaining from the use of antimicrobials in mild and moderate cases, where severe cases would probably need empiric therapy with proper de-escalation plans in place. Of course, easily said, very difficult to be done, especially when patients are intubated with multiple lines in place and poor hygiene situations that can be the case. Specifically, it was painful to watch some of the extremely overcrowded ICUs and patients being managed in corridors. Very difficult. We also have produced the Antimicrobial Stewardship Program toolkit and a policy guideline that I think Joseph will talk more about. And we also work very closely with another department within WHO on water sanitation and hygiene in healthcare facilities. So there's a wealth of information, including also the WHO model list for essential medicines. Also, diagnostics is being worked on at the moment, and we're also working on developing a survey protocol that we can now address the SDG indicators on antimicrobial resistance, which include bloodstream infections for E. coli, ESBLs, and bloodstream infections from MRSA. I think you're all very aware of the Antimicrobial Awareness Week. I think I kind of gave it away by giving the dates already. But I also wanted to mention that we were very keen on changing it from Antibiotic Awareness Day to Antimicrobial Awareness Week. And as we're expanding our functions within the WHO to ensure that all types of resistance to all types of antimicrobials need to be addressed, what I do say to lay people is that we need to be treating antimicrobials with respect. In comparison, we do not give anti-cancer medications just in case someone has a cancer. We do not give anti-diabetic medications just in case someone has diabetes. Yet we tend to give antimicrobials not only by healthcare providers, but over-the-counter dispensing of antimicrobials, sharing with family and friends, and even giving them names that are not even accurate, such as gastric cleansing agents. So I think we need to work very closely with partners who can help us in this space. We had a great webinar a few hours ago with civil society, and there's a lot that's taking place. And I think that we are happy as WHO to partner with all associations and societies, and we're happy to be guided, but by what we can do more to help you do your work and for you to help us do our work. So what can you do for WAAW? I think your voice is extremely important that we will be going blue, and we will have a robust campaign even more next year. I think making linkages to the others within the different healthcare systems and within the non-healthcare systems, as I mentioned, civil society is crucial. And I think it would be nice for the societies to also link with the non-human associations and societies, for them to understand the suffering that's taking place from the human health sector. But there's also, and I acknowledge that there is suffering that's happening from the animal sector, where sustained economies need to take place. And that's where I want to encourage the young researchers and scientists to really focus on the innovation that needs to be done within the full ecosystem of the animal environment, water, and human health, that we need to separate the innovation that will ensure usable agents for treatment and prophylaxis, if needed, are available for humans and animals, and that we do not have to share the same agents, which is the case today, but also innovation in how to make hygiene and infection prevention and control accessible and clean, also for the human, animal, and the environment sector. How do we work with the pharmaceutical companies on ensuring that the environment is not contaminated, and so on and so forth? So supporting through your institutions is extremely important, and I think we're looking into major campaigns that are taking place. So my final slide is just to show from the very, very early this week, where we had in the center here the WHO building going blue, but also from PAHO, our office had their meeting, which was very blue. Of course, I'm also blue. And our CRO office. So we have more photos that have come in since the preparation of this presentation, and we will probably be sharing it within our newsletter. So please ensure that you do take a look at our newsletter that happens on a quarterly basis. And I'm happy again to be with you, and thank you very much for your attention. Chris, over to you.
Thanks so much, Dr. Balkhy. Right now, if you have a question for Dr. Balkhy, please type it in the Q&A, and our discussion will be moderated by Dr. Morris and Dr. Hamdi.
Thank you again for that, Dr. Balkhy. That was a fantastic talk. Really exciting to hear you speak on this topic. We had a couple of questions for you. The first being, what do you see as one of the biggest barriers to implementing antimicrobial stewardship programs, specifically in some of the low and middle income countries? I know there are a lot of barriers, but what do you see as some of the bigger barriers that we face?
Thank you, Lee. Beautiful question. I think the first, maybe a few years ago, I would have given a different answer, but after being here for 2.5 years, my answer would be several, but I think it's the diagnostic part, the lack of understanding what the patient has. That's one thing. The lack of easy, quick access to healthcare systems, primary healthcare specifically. The fact that antimicrobials are cheaper than a diagnostic test, and the fear of the healthcare providers of not being able to follow up on their patients. So by providing the therapy, just in case, seems to be a good way for solving some of these problems. So I think it's a multiplex of problems, and hence my comment on the need for innovation that can afford the tools that are cheap, effective, and accessible and affordable.
So that kind of leads me into my next question, which would be, what would be one of the most important first steps that you would say people need to take moving forward, whether that's at a national level or at a more local level as well? Would love your input on that.
I think at the international level, as I said, I think we need to make sure, and maybe this is core to WHO's mandate, we need to know how do we get the attention of the policymakers and the financial sectors, because they're the ones who are going to put the dollar against the activities that are needed. And if we do not have a clear return on investment number, if we do not have a clear assessment of the burden of this disease, also within the different categories, it's difficult, because you use the listener once you say AMR, and then you just start wanting to try to describe what is AMR, they're gone. So we still are not able to have that elevator pitch of antimicrobial resistance. And what does it mean? We are working very, very hard to ensure that we are able to create or to push for those numbers to be developed. So I hope that within a year or so, those numbers will be available, because the different pieces, the IPC, the PIDS, you guys, the different societies, there's a lot of bits and pieces of the AMR work that's on the ground already, but they're not supported enough. And I think I gave the example of IPC that was very clear.
Thank you so much.
We have a few additional questions in the Q&A from one of our participants. How can we best advocate for training next generation healthcare providers on best practices for limiting antimicrobial resistance?
Great question. And it's the healthcare providers, all of them, the RTs, the nurses, the pharmacists, the physicians, every single one of them. We are already looking, and many countries around the world, and health and education programs are already looking in incorporating the bits and pieces of AMR. We have developed a few years ago, but have not launched it strong enough in AMR curriculum. So we're going to be working on that as well. But again, it's fragmented. And again, it's about infection prevention and control. There's courses and workshops on hand hygiene, and they don't understand why do we really need to do it, or if we do it sporadically. The same thing when it comes to interventionists in inserting lines. How do you insert a line? I looked at one of our simulation centers back home, and in training young doctors on inserting central lines, I demanded and asked them that, can you do the donning and doffing and IPC part, even though it's a mannequin? So in training the healthcare providers to intubate and put a central line, it's about the technique, but it's not about the IPC part that goes into it. So it does not become part of their DNA to do IPC practices and to practice the proper methodologies when it comes to preventing infections. Removing lines, mobilizing patients. We know all the risks that cause healthcare associated infections. So how can we now start moving into making sure that we don't put a catheter, a bladder catheter, in a post-spinal surgery patient just because we can't take them to the bathroom, right? So that those practices do happen. So those are the things that need to take place. We need to make the curricula clearly addressing the stewardship, IPC, and diagnostics as part of mitigating AMR and bending the curve on multi-drug resistant pathogens. And I think healthcare providers, during their daily rounds, they need to know what an antibiogram is. They need to know the cumulative burden of drug resistance in their healthcare settings. And many high-income countries do have that luxury. Many do not. So, but at least those who have it should probably use it.
Yeah, absolutely. And one last question for you, Dr. Balkhy, before we move on to our next speakers. How do you envision partnerships between professional societies such as PIDS and the WHO in being most effective in leveraging our expertise to promote our common goal of combating AMR?
Thank you, Rana. That's a beautiful question, and I'm sure Thomas is taking note. As I said, we had a very nice intervention before this one. And I think, first of all, I think we have to have a more continuous dialogue. And I think we need to understand each other's work much better, not just for PIDS, but for the other societies. I'm available, our teams are available to communicate with you on what can be done, especially PIDS is now moving into global health agenda. So I think there's a lot that you can provide and leverage the work on, especially with the expertise that I very much know that PIDS has. The platforms and the journal that you also have, WHO is very much encouraging that they all go open access to make available the data to the mid-low income countries. So that's something we're encouraging, and also encouraging the patient's voice within the publications and that you might have. That's something that, again, I learned today, actually. So there's a lot that can be done. The question is finding the time to communicate, identifying our joint priorities, but also I think we can all help link each other with other organizations and platforms. So I hope that with COVID, hopefully slowing down a little bit, but we can still continue to try to find those leverages, and I'm happy to help in any way.
Absolutely. We all look forward to that. Well, just wanted to thank you again, Dr. Balkhy, and for being here and for that wonderful presentation. And
thank
we'll
you, everyone.
Move on to our next presentation.
Thank you, and enjoy the rest of your session. Thank you so much, everyone.
our next speaker today is Thomas Joseph. Thomas, please feel free to share your slides.
Thank you. Thank you very much, Chris. Are my slides visible?
Yes.
And am I audible?
Yes, we can hear you well.
Very good. Thank you. Thank you very much, Chris, and everybody at PIDS for inviting Hanan and me to this wonderful webinar. My topic is the WHO policy guidance on integrated antimicrobial stewardship activities. And just to quickly say that this was developed, after extensive consultation with experts from around the world. Some of you probably were part of it, which then culminated in drafts being developed and then a final draft being reviewed at a global consultative meeting in December of 2020, from which a final document emerged, was approved, translated into all UN languages, and is available at the link that is below there. It looks like the left-hand side. So what is the purpose of this guidance? The purpose of this guidance is really to help all stakeholders, particularly government, but also the private sector and civil society, to work together to develop more coherent, integrated antimicrobial stewardship programs at national, subnational, and hospital and facility levels. So I'm going to start with the definition of antimicrobial stewardship. And I'm going to take it in 3 parts and go over it a bit slowly, because I think this is central to a broadened understanding of what stewardship is. And I draw your attention to the fact that we take it well beyond the patient-physician interface. So WHO defines antimicrobial stewardship as a coherent set of integrated actions which promote the responsible and appropriate use of antimicrobials to help improve patient outcomes across the continuum of care. I draw your attention to the picture, and we're basically saying it requires many stakeholders across disciplines working together, coming together to make a coherent picture, which can only happen if all the pieces fit together well. So this is important, it's integrated, coherent. The second part is to understand what responsible and appropriate use of antimicrobials means, and we say that this includes prescribing only when needed, selection of the optimal drug regimen, drug dosing, route of administration, and duration of treatment following proper and optimized diagnosis. You're familiar with this, but I'd like to draw your attention again to the picture to give an image of a painter, let us say. The idea is that we do not want this to be somebody who's, painting a wall with broad brush strokes of, if you like, with broad spectrum antibiotics, but an artist who is selecting the right colors, putting them in the right place to create a work of art so that each individual patient is treated according to their individual pathogens and the required antimicrobial. So this is critical, that responsible and appropriate use of antimicrobials must have a proper diagnosis and must have the optimal drug regimen, dosing, and route of administration. And finally, the definition goes on to say that these actions are complemented by access to affordable and quality antimicrobials and interventions that prevent healthcare-associated infections and community-acquired infections, including the core complements, including the implementation of core components of infection prevention and control, enhancing water sanitation and hygiene, and optimizing vaccination coverage. So here again, what we are saying is that prevention is as important to an understanding of antimicrobial stewardship as the rest of it. And that we have to look at vaccination, we have to look at IPC, we have to look at WASH as integral complementary elements that we must pay attention to if we are to reduce the use of antimicrobials and thereby reduce the growth of antimicrobial resistance. So these work together, one supporting the other. And we are presenting our set of integrated antimicrobial activities as a package so that it is a programmatic approach to antimicrobial stewardship. It has 5 pillars, and the visual here again is that of a house. If one pillar is not there, house is a bit weaker. 2 pillars are missing, house is very weak. If 3 pillars are missing, the house will not stand. So we must see these different pillars as critical, working together and combining to produce an excellent result. And each of them is important. What are these 5 pillars? I will take you through them more slowly, but quickly. The first is about establishing and developing national coordination mechanisms for antimicrobial stewardship and developing guidelines. The second is about ensuring access to and regulation of antimicrobials. The third is about improving awareness, education, and training. The fourth about strengthening water, sanitation, and hygiene, and infection prevention and control. And the fifth is about surveillance, monitoring, and evaluation. So here's the first pillar. We're talking about improving coordination, and this is critical. We need to have at the national level and at the subnational level and at the level of the hospital mechanisms that help bring together the various actors and stakeholders so that there can be coordination between them for what is required for antimicrobial stewardship. At the national level, this can be placed within an existing structure. It doesn't have to be something new, but it does need to be a specific designated mechanism that works to look at the issues of antimicrobial stewardship. And this mechanism should be responsible at the national level to issue guidelines and guidance that can affect practitioners, can affect physicians, pharmacists, that can affect all prescribers so that they are better able to engage with patients. So this could take the form of, making sure that there is a national essential medicines list and that list is actually available to everyone, or to make sure that the aware classification, the antibiotic drugs being classified as access drugs, which you can use, the watch drugs, which you must, take with caution, and the reserve drugs, which really should not be used unless absolutely necessary. So access, watch, and reserve. Trying to link the aware classification with the national EML, creating maybe an antibiotic handbook that can describe to physicians the common infections and the drugs for them, and also provide other types of guidelines to facilities on all sorts of requirements for antimicrobial stewardship, including WASH and IPC, so that facilities increasingly are places where infections are less and treatment and cures are greater. So who does what, where, when, how, and why? This is the responsibility of a mechanism that must issue these guidances as required to all the stakeholders who need it at all different levels. This is critical. The second is about access and regulation, access to antimicrobials. As you know, in many LMICs, more people die because they don't have access to antimicrobials than because of antimicrobial resistance. So this is critical. And if you don't have access to antimicrobials, then you're likely to, which are first-line drugs, then you're likely to use reserve categorization of drugs for treatments, more broad-spectrum drugs, if you like. And that is unfortunate and unnecessary. So we need someone to ensure that there is access to all to the antimicrobials that are needed, through the supply chain and so on. But once you've done that, once you've got all the access, you also need to ensure that it's not misused or abused, and that there is regulation to support it. Regulation that allows behaviors to adhere to the right way of doing things. So how do we do that? How do we change these behaviors? Whether through incentives, maybe our physicians, or maybe our physicians and pharmacists, the structure of remuneration is inadequate, and therefore there are inducements that they follow, which may be unhealthy. Can we change that? Or can we use legislation, make the laws that are needed, the penalties that are levied, so to prevent people from doing what they should not do? Can we use regulation to make sure that the rules speak to what we want to achieve? What other measures can we do? The point is that in every situation, whether it's at the national level, whether it's at the facility level, we need to think through these sorts of issues on behavior, and we need to create the rules and the laws and incentives that will provide the right way of dealing with antimicrobials. The third pillar is about awareness, education, and training. As you know, we are in World Antimicrobial Awareness Week, and there's good stuff which Hanan showed you happening across the world. But that's not enough. That's just a week. We need to do much more in terms of education, and particularly we need to think about our own healthcare workers, pharmacists, and so on, and to ensure that there is pre-service training, there is in-service training, there is continued training, so that the message of antimicrobial stewardship becomes more robust, more understood, and hopefully filter down into better prescribing and consuming behaviors. The fourth pillar is around water and sanitation, hygiene, and IPC. You know, it's the question that someone asked about LMICs. The fact is that in many LMICs today, even clean water is not available in healthcare facilities. Forget about in the community. Without clean water, how can a hospital or a healthcare facility run a hygienic facility? So many without toilets, many without waste disposal systems. So there's a huge need for investments in water sanitation and hygiene. There's a huge need to really push this agenda as an important complementary aspect of antimicrobial stewardship, so that WASH becomes a reality, not just at the facility level, but also at the community level, that in households where people live, where they gather, where they go, the environment is clean and infection is reduced. But also, of course, all the important aspects of IPC that Hanan talked about and emphasized, and the guidance that is available from WHO to make sure that the core components of IPC is practiced in every healthcare facility. This is critical. So that's our fourth pillar, along with vaccinations to prevent infections in the first place. And the final fifth pillar is surveillance and monitoring and evaluation. In surveillance, we're talking about, making sure that we understand, how antimicrobials are used at the level of the patient. And, we've got the WHO methodology for point prevalence surveys on antibiotic use in hospitals, which has been taken up by a lot of hospitals across the world, and hopefully will continue to be taken up by many, many more, so that there's a greater understanding of antimicrobial use. But also in the aggregate, we need to understand antimicrobial consumption, whether it's at the facility level, whether it's at the subnational level, the district level, or at the national level. How much of what are we consuming, so that we see the trends and we try to understand, what it is that we may be doing not so well and maybe doing well. And finally, of course, antimicrobial resistance itself. We need to make sure that we have the kind of drug sensitivity testing that allows us to understand the patterns of resistance that is being developed. And this must be supported with monitoring and evaluation. One of the key indicators that we would like to see is the proportion of access drugs to the total number of drugs, so that we understand, how much of the access classification of the aware classification is being used compared to watch and reserve. And our expectation is that at least 60% as a minimum should be access type of drugs. And if it's more than that, we may want to have a closer look at what's going on at the level of the facility or the country. But also the proportion of access to watch to reserve antibiotics in pediatric formulations. What are the proportions that we're seeing there? And finally, the implementation of the integrated antimicrobial stewardship package. So looking at all 5 pillars and making sure that we are assessing periodically what is going on, the baseline situation with regard to these pillars. And as we progress, we keep seeing the gaps that we have maybe, or the successes that we've achieved, what needs to be consolidated or what needs to be built upon. Finally, all this is talk and will remain talk unless it's implemented. So it'll be a pie in the sky, which I think is an Americanism that I'm taking the liberty to use. But the implementation considerations I want to emphasize, and that is emphasized in the policy guidance, is to see this holistically, to see this as a spectrum that needs to have coherent and integrated action. So please establish coordination mechanisms. It's very critical, so that that mechanism can be responsible for stewardship at every level. Understand the situation through baseline assessments and situation analyses, and continue to monitor these. Develop a national policy on integrated antimicrobial stewardship activities, develop implementation plans and budgets, but make sure that these implementation plans and budgets are costed so that you have actual funds to use it, and then mobilize the resources required, whether human or financial, engage in advocacy and awareness raising, and finally, build capacities to implement these plans. Thank you very much. And please go blue for AMR this week at least.
Thomas, that was a really terrific talk and very thought-provoking. Thank you. Our final speaker is Dhanya Dharmapalan. Dhanya, if you'll pull up your slides, we'll have questions at the end. So thank you again.
Thank you for the opportunity to present here my perspective about the pediatric AMR and ASP in Indian children. India is home to 1.3 billion population. 30% are below 15 years of age, and 1/5 of the world population under 5 years of age reside here. So India has a significant impact when it comes to global pediatric health scenario. Here, the healthcare is provided by allopathy, which practices modern medicine, and Ayush, traditional medicine. Ayush stands for Ayurveda, Yoga, Unani, Siddha, and Homeopathy. And it is by combination of both are we able to achieve the WHO recommended minimum doctor to population ratio of 1:1,000. It is important for me to highlight that the majority of Indians receive healthcare through private sector. So 80% of outpatient services and 60% of inpatient services are provided by the private sector and rest by government. So it is out of pocket expense for many. India has high under 5 mortality rate, but if you look at the district level mapping of this trend, we notice that it is not uniform. The districts which are coded red and orange have high mortality rate, yellow, medium, and the ones in blue have low mortality rate. So the quality of healthcare actually depends on where you are living in the country. The leading causes of under 5 mortality are lower respiratory tract infection, prematurity, diarrheal diseases, and sepsis. Since there is huge burden of bacterial infections, India is also largest consumer of antibiotics. And because antibiotic use itself is a driving force for multi-drug resistance, it also has the largest burden of multi-drug resistant pathogens. In 2017, we reported high rates of antimicrobial resistance in Indian neonatal and pediatric bloodstream infections. This was a descriptive review spanning over 15 years, and we found that 50% of Staph aureus isolates in our study were methicillin resistant, and a commonly isolated bug, Klebsiella pneumonia, was resistant to ampicillin to the tune of 95.9% and gentamicin 75%, and even the resistance to cefotaxime was over 60%. So we concluded that there was high rates of resistance to WHO recommended first-line treatment options for sepsis in children. And our study is supported by this conclusion by a recently conducted systematic review and meta-analysis published in PLOS in 2021, stating that there is significant rates of resistance to WHO recommended both first as well as second line empirical antibiotics. How does this matter? It matters a lot because of the conclusion of this study, which also included our data, that the odds of mortality in confirmed pediatric bloodstream infection are nearly 3-fold higher for children who receive discordant early empirical antibiotic regimen. Therefore, it is very important to be right in the beginning of the treatment. This is one of the common outpatient infections that we see. Streptococcus pyogenes, pharyngitis. This was an outbreak investigation and the first genome report from Indian public database of Streptococcus pyogenes, and we reported that the isolates harbored genes responsible for multi-drug resistance, and macrolide resistance was to the tune of 30%. How is this concerning? Very concerning, because during the COVID pandemic, there has been a huge consumption of macrolide, this azithromycin, despite trials showing no benefit of azithromycin against COVID-19. As you can see from this paper, which looked at the sales of azithromycin over June and to September 2020, which coincided with the first peak of pandemic, there was 38 million excess doses of non-child attributable formulation of azithromycin sold, equivalent to a minimum of 6.2 million azithromycin treatment courses, raising concerns for antimicrobial resistance among macrolides. Now, India has the highest MDR-TB and XDR-TB in the world. India contributes 28% of global burden of pediatric TB. And you can see this is a report from a single center from Mumbai, a government hospital, where they reported the drug-resistant profile of tuberculosis in children. And of the 268 children, it is alarming to note that 13% were XDR-TB. Now, if we compare the time of evolution of antimicrobial stewardship practices between the two countries, US and India, we realize that in US, the evolution has taken place gradually over half a century. So the basic services, the clinical pharmacy services, infection control services were set up first, then came the guidelines, and then came the mandatory requirement by JCI for institutional accreditation. In India, on the other hand, after the report of NDM in 2009, there were rapid measures taken by the government with release of excellent guidelines for containment of AMR, treatment guidelines for infection control, as well as a red label was applied over the antibiotic cover, so to prevent the over-the-counter sale of antibiotics. But all this has taken over just in past 10 years. And unfortunately, the improvement in the basic infrastructure, the basic health infrastructure has not coped up in this speed. And as apparent in this paper, which looked at assessment of core capacities of ASP practices in Indian hospitals, and here 20 hospitals had participated. Most of them were large hospitals, premier hospitals of India, and yet there was a lack of personnel from pharmacology, pharmacy, infectious disease, and IT, so crucial for the programs which are practiced in the West. Sorry. This is Government of India surveillance report between 2016 July to December, and they found that none of the district hospitals were performing blood cultures. So this is currently being ramped up. But what if culture report is available? Suppose I have a child of 4-year-old who has severe pneumonia. I send a blood culture. It grows methicillin-sensitive Staphylococcus aureus. We all know the drug of choice. It's written in all the guidelines: cloxacillin, oxacillin, nafcillin, cefazolin. But the question is any available? So because of lack of availability, we resort to broader spectrum antibiotics, which are less effective and also lead to more resistance. We surveyed over 800 parents and found that only 1 in 4 actually could identify what antibiotics were used against, and still lesser, 15% actually knew the term antibiotic resistance, indicating poor awareness about this problem in common people, and therefore also one of the reasons to resort to self-medication. Now, at professional level, the reasons for misuse at individual level could be due to lack of time, because of the sheer volume that an Indian doctor treats. Because of the low doctor to population ratio, they can end up treating 100 to 200 patients per day, and they do not want to miss a possible bacterial infection. So antibiotics are misused. Then there could be other reasons such as lack of confidence, lack of awareness about resistance, poor clinical skills, peer pressure, fear of losing a patient to a prescriber across the street who might write an antibiotic and take credit for curing a viral infection, pressure from patient, pharma influence, lack of leadership support at institutions, interprofessional level, senior junior hierarchy is an important cause. India is a country where teachers are worshipped and wisdom is taken for granted. Extremely difficult it is to challenge this wisdom. Then there could be ego clashes, opposition by prescribers, and poor communication in suggesting change. Indian Academy of Pediatrics has been very active in promoting rational antibiotic practices through various educational tools. We have also tried novel methods like posting on social WhatsApp media daily tips on rational antibiotic usage, but all these efforts, unfortunately, are not even a drop in the ocean for 0.4 billion vulnerable children in India. So the potential solutions: one, AMS needs to be customized to low middle income country. It cannot be simply extrapolated from resource rich settings because simply we don't have so many luxuries here. At subnational level, we need district-wise mapping of antimicrobial resistance, at least of the high priority pathogens. And for this, we require culture facilities to be easily available everywhere. We need better point of care tests. We know how nucleic acid amplification test has revolutionized the diagnostics in tuberculosis, and we want more of such point of care tests. Train all healthcare workers, including pharmacists and paramedics and nursing staff, in rational antibiotic use and infection control. Regimens need to be customized to local AMR prevalence. An empirical antibiotic regimen system is being developed currently by the Apollo Hospital Group. But it is important to make those recommended antibiotics available for the doctor to use and let them be not just on paper. Public education and awareness is must. This is the biggest lesson we have drawn from COVID-19. Without public support, it is impossible to achieve a reduction in AMR. And since the awareness about hand hygiene, respiratory etiquette, and vaccination is at the peak now, we must take advantage of this and help to prevent bacterial infections. Ironically, India is the IT hub, but still the IT system is lacking in healthcare sector of our country, and we require IT for AMR related surveillances. There is a potential to reduce AMR by integrating traditional medicines. This is food for thought, an underexplored area. We need stringent laws, but actual implementation on ground is more required. Better health infrastructure, certainly, and more research in children, especially for novel diagnostics and antibiotics. I must point out that the fee to publish a single article in a high impact journal is equivalent to total earnings of an Indian medical school teacher for over 4 to 5 months. So in the background of lack of institutional funds and funds which do not include publication fee, even publishing good research article becomes difficult. Challenges in dealing with rising AMR in comparison to handling the COVID pandemic are much greater, as we humans are responsible here and not a virus. And it's a united global fight because no country is safe for COVID-19 or AMR until every country is safe. Thank you.
Dhanya, Thomas, thank you so much for your excellent talks. I think it's really important work that both of you are involved with, and thank you so much for sharing that with us today. I realize that we are a little bit over time, given some of the technical difficulties we had at the beginning, and so we understand if you have to jump off the webinar, but we still wanted to give an opportunity to address some of the questions that have come in through the Q&A. Luckily for us, I think a lot of this has already been addressed through Thomas's presentation and also through Dhanya, so thank you for that. You inadvertently answered a lot of the questions that have come up, but there's a couple more that remain. One of them, and I know, Thomas, this one is for you in particular, and it's something that we've discussed in the past, but one of the questions was, how can pediatric infectious disease subspecialists throughout the world become more involved with the WHO's work on antimicrobial stewardship and resistance at the WHO level globally?
Sorry, Lee, were you talking about PIDS in particular?
No, just any pediatric infectious disease specialists that have an interest in stewardship and resistance. How do you feel like they could become more involved with some of the work going on at the WHO's level?
So, you know, I'm not sure that I have the full answer, but I can give you some sort of ideas. In every country, we are hoping to set up, and we are setting up, encouraging the setting up of national action plans, and those national action plans generally are backed by some sort of committee, steering committees of some sort, which bring together different stakeholders. So I think it's important that there should be the participation in those committees of pediatric infectious diseases as a sort of requirement. So if pediatric infectious diseases are organized in national terms, just as you are internationally, then, you know, one seat at that table could obviously be provided to, but that's at the national level. At the local level, of course, I mean, it is critical that, you know, that there should be conversations of experts around these issues. So at in each hospital, the stewardship committee that we hope will be established, it's part of our guidance, that there should be a committee to steer stewardship. And these must have stakeholders from different disciplines, you know, from radiology, from the lab, but also from infectious diseases and perhaps from pediatric infectious diseases in particular, who must come together to look at stewardship in that way. As far as WHO globally is concerned, in terms of the international organization, we are hoping to develop some relationships with civil society that are more systematic. And, you know, we've been in conversation with PIDS for a year now, and we've had 2 events, last year one and this year one. And this augurs well for the future, and maybe we can do more together. So, you know, we need to watch that space as well.
Great, thank you. And I wanted to just also point out, there was another suggestion that you had made in the past, which was signing up for the WHO's Antimicrobial Resistance newsletter that comes out periodically. And within that newsletter, there's often opportunities as well to volunteer in different capacities through the WHO. So there's a call for volunteers that come through that, and that's another way to become involved as well. So thank you, Thomas. Appreciate that answer.
Thank you.
And there are also numerous questions from participants focusing on education to practitioners. It was great to hear from Dr. Dharmapalan about an example of educational initiatives targeting clinicians using WhatsApp with the tip of the day. From each of your perspectives, what do you see as the next steps in education to providers?
Education has to be persistent. We have to keep repeating the same principles again and again. Maybe out of, I mean, I cannot say exactly, but maybe just 1 out of 50 may convert. But that's the only way we can go about in education. We just have to keep repeating the same things again and again.
I think I can just add to that and say that I consider this a critical issue. As you know, it's one of our pillars of stewardship, that we must have education and continuing education. One of the things we are doing to make that happen as WHO is we have published a draft of what we are calling the Essential Medicines List Antibiotic book. And that is up on the web for consultation till the 31st of January. Everybody is welcome to have a look at it and to see. And it describes the formulations for all the common infections that we have. So what are the treatment, what is the dosage, what is the regimen, you know, what is the route of administration? All this is defined in this antibiotic book. And we hope that once we've got all the public feedback, that we will in June publish it. And then I'm hoping that we can actually create an app that can go on your phone. So if you're a prescriber, if you're a physician, you know the infection that you have, and then you just use that app and it will give you the sort of antibiotic that you should be using, the best narrow spectrum antibiotic, hopefully available in your area, because of course so many countries don't have all of them. So these are some of the things that we are doing, but we're also emphasizing pre-service training, in-service training on AMR.
And I would like to add that we should start young. I think we should prime even the school students about antibiotic resistance. I think we should start young.
Yeah, absolutely. Great. Well, thank you both so much. I'm sorry we didn't get to all of the questions, but I'll hand it over to Dr. Bryant to wrap it up. Thank you.
Thank you, Dr. Hamdi. I just want to thank our presenters today, Thomas Joseph, Dhanya Dharmapalan, and the PCAS for organizing this, particularly Dr. Hamdi and Dr. Morris. I was struck by the breadth of today's presentations. Everything from big picture, what can we do at the cooperation? How can PIDS and WHO collaborate? That's really big picture, to what can we as individuals do to prevent antimicrobial resistance and promote stewardship. I'll close with an important reminder that we do have scholarships available for the International Antimicrobial Stewardship meeting. You can see the application process on your screen. If you are eligible, I encourage you to apply. And I'll just again close with my thanks for everyone who signed in today. Thank you again. Bye-bye.